Hello, Amit.
Good evening, sir.
Good evening, Amit. Uh, I just wanted to make sure I kept my slide open at the back. So when share screen comes, I'm supposed to just click on that, no?
Yeah, sir, you can try once. Right now, you can share, sir.
Yeah,
Yes, sir, visible.
visible, no? So I'll stop sharing and I'll do the same thing again later. So this can be there in
Yes,
the
sir.
background, no?
Yes,
Yeah.
sir. Right now, unless you share it, it won't show it here.
Correct. So it's there. So fine. Okay, got it. Then how are you?
Bus fine, sir.
Okay.
Ready to roll.
Ready to roll. That's what I wrote to Vani also just now. I said I've set up upstairs. She's gone out for a walk.
Acha. Yeah. So, actually, we are little early, but I have just started it.
No issues. We start at 7
It's
sharp.
also live on YouTube also.
Ha. Hello, Sunil. Good evening. Nice to see you.
Good evening, Dr. Sunil, sir.
Good evening, sir. I thought I was on mute. Nice to see you after a long time,
I
sir.
know, Sunil. Yeah, I think that's why you were speaking and I couldn't hear you.
Yeah,
Good evening, Sunil, once again. Yeah.
yeah. Thank you, sir.
Hello, Ravi.
Good evening, Rakesh. Good evening, Ravindra sir.
Namaste, sir. Namaste. Good evening.
Good evening,
Hello,
sir.
Rakesh. Hi, good evening. Hi,
How
Rakesh.
nice to see
Yeah,
Ram
namaste.
Kumar, sir.
Sir, welcome. Namaste, sir. Welcome, sir, for
Really,
sparing
sir,
time.
really seeing Ram Kumar, sir, is a wonderful thing.
Yeah, Ravi, so close yet so far. We are not too far away
Yes,
from.
sir.
Yeah.
I know. I know.
Yeah.
Sir, how is everything? Manipal.
All well. Yes, all well, Ravi. Thank you. You must be getting ready for the conference.
Yes, sir. AOA National Conference to take this month.
I
They're
think,
doing it, sir.
yeah, Ravi, at present, I think there is your voice is breaking. So I want to check with Rakesh and Amit whether my voice is heard. Okay.
Your voice is good, sir. Ravi's voice is breaking.
Okay. Yeah.
Okay.
Yeah, Ramkumar, sir, you're clear. Yes, sir.
Rakesh.
Let me make some arrangements for the with the cable internet connection.
Sure.
Give me 2 minutes.
Good evening, those who have joined. Thank you very much for joining early. We'll be starting soon in next few minutes as more and more anesthesiologists are joining us. We'll just wait for a few more minutes and then start.
Sure, Amit. Yeah.
Good evening, Sunil.
Good evening. Good evening, Ravi.
Is my voice clear now, sir?
Better.
Yes.
Thank you so
Not
much.
breaking now. It's good. Yeah.
Yeah, thank you.
Amit, sir, we can start. I think it's 7-1.
Okay. Good evening, dear friends and colleagues. Welcome to our 8th edition of Airway Quizinar series, our run-up to the National Airway Conference and International Airway Management Meeting 2026. Welcome from the All India Difficult Airway Association. I am Dr. Amit Shah, General Secretary, All India Difficult Airway Association. The NAC 226 is a proud collaboration between All India Difficult Airway Association and International Airway Management Society. So we are jointly hosting this meeting, National Airway Conference and International Airway Management Meeting, in 9th, 10th and 11th October at AIIMS, New Delhi. The heart of today's sessions, we are focusing on one of the most high-stakes environment in our field, that is obstetric. Management of unanticipated difficult airway in a pregnant patient requires not only skills, but precise evidence-based strategy, focus, mindset, where every second counts and there is more than one life at stake. So to guide us through this, the airway AIDAA 2025-26 guideline for airway management in obstetric patient, we are incredibly fortunate to have a lead author of guide himself, Dr. Ramkumar sir. Welcome, sir. Also, I would like to acknowledge the other chairpersons of this evening. So Ramkumar sir is a former head of the department, KMC Manipal. He is a founder, president of All India Difficult Airway Association, pioneer of respiratory therapy in India, chairman AIDAA Guideline Committee of 2016, trustee of Mission Smile in India, and he is lead author for this guideline. Next, we have Dr. Bharti Wadhwa, director, professor, MAMC, New Delhi. She is a chief editor, Yearbook of Anesthesiology, national coordinator, webinar program, NBEMS, faculty expert at Delhi University and the NBEMS. And she is coordinator, examiner for DNB and various anesthesia exams. Dr. Jil Ravindra is from Simoga, chief consultant, Janani Anesthesia and Critical Care. Has extensive obstetric experience, including 13,000 plus labor epidurals. Former professor and head of SIMS Simoga, president ISA Karnataka State branch in 2003, and got, of course, special interest in obstetric and regional anesthesia. Welcome, Ravindra sir. Dr. Anju Grewal, she is professor and head Department of Anesthesiology, AIIMS Bhatinda. She is current national president of AO India, editor-in-chief of WFSA Anesthesia Tutorial of the Week, which is tutorial from the World Federation of Society. Numerous publications, chapters, fellowships. Dr. Sunil Pandya, chief of Department of Anesthesia, Perioperative Medicine, Critical Care, AIG Hospital, Hyderabad. He is also consultant anesthesia and obstetric critical care at Fernandez Hospital, Hyderabad, co-founder and director of Prerna Anesthesia and Critical Care. And also, he is a founder, member, and president of AOA. And he's absolutely well known for his knowledge and his enthusiasm for obstetric patients. Dr. Kajal Jain ma'am, unfortunately, she is in Indonesia. She is not able to join because her internet connection is really poor. But she is professor and head Department of Anesthesia, Intensive Care, PGIM at Chandigarh. And she has a special interest in obstetric anesthesia, critical care, and trauma care. And she is immediate past president of AOA. So welcome all chairpersons. As we dive through the obstetric guideline, there are a lot of important topics, lot of important consideration. And compared to 2016 guideline, this time, this was in collaboration with AOA. So this was in collaboration of AOA, and two of today's chairpersons are actually also part of authors of the guideline. So let us dive into guideline further. Over to Dr. Rakesh.
Thank you so much. I think we are so fortunate to have all the dignitaries with us. So without wasting time, I would request Dr. Ramkumar sir to take us forward through how these guidelines came up and what are the features of it and how to use them into clinical practice. So over to you, sir.
Thank you, Rakesh and Amit. And Amit, can I start sharing my slides, please?
You can share.
Just let me know if it's seen.
Well, sir, it's
It's
clear,
been-
sir.
Okay. So I think we'll get started. Once again, thanks to Rakesh and Amit for organizing this series of airway Quizinars. We've already had two of the guidelines presented, the adult guidelines and the pediatric guidelines. And going for the third one in the series at fortnightly intervals, today we shall discuss the 2025 obstetric guidelines. So this is the paper, the guidelines paper that came out in the Indian Journal of Anesthesia, November 2025 issue. And we have the names of 14 authors who went in depth into the nitty-gritty details of obstetric anesthesia and also looked at how things have changed since the last guidelines came out in 2016, almost a decade earlier, how the practice of anesthesia has changed, how new equipment has come into the picture, how our understanding of certain gray areas has put us on the right path. And my sincere thanks to all the members of the obstetric committee for putting this guidelines together. Now, as Amit already mentioned, this time around, the last 2016 guidelines, we had included airway experts from within the All India Difficult Airway Association. But this time around, we wrote to the then president of the Association of Obstetric Anesthesiologists of India, Dr. Kajal Jain, and requested her to suggest names of 3 members, senior members who would help us to fine-tune the obstetric guidelines. And Dr. Kajal was kind enough to include Dr. Anju Grewal and Dr. Aruna Parmeshwari along with herself. Our sincere thanks to the Association of Obstetric Anesthesiologists for lending their expertise and making our guidelines more robust. Now, why do we need to have separate guidelines for obstetric anesthesia? Like we started with the adult guidelines, which give us the general outline for managing a difficult airway in general. And the second lecture looked into the details of how the guidelines need to be changed or need to be looked at from the pediatric angle. And in today's session, we'll be talking about the obstetric angle of difficult airway management. So what makes obstetric anesthesia different is that, as Amit already mentioned, this is the only branch of anesthesia where the anesthesiologist needs to keep in mind the well-being of 2 lives, the mother as well as the baby. And the anesthetic technique of choice has changed over the years. Now, when I was doing my residency more than 4 decades ago, 9 out of 10 anesthetics for cesarean delivery were a general anesthetic. But over the years, thanks to the various studies that have gone into the reasons for maternal mortality, like the confidential inquiry into maternal deaths from the UK and from the United States, we have now, over the years, the last 2 decades or so, gradually changed our primary management, anesthetic management for cesarean delivery from a general anesthetic to a central neuraxial anesthesia, most of the time a spinal anesthesia. Having said that, there are still a few obstetric patients, a few parturients who will still need to be given a general anesthetic. And these would be primarily those who have some problem with the spine, people, the parturients who have a coagulation issue, which does not allow us to go for a central neuraxial technique, plain and simple refusal for a central neuraxial block by the mother. And of course, when there is a maternal and fetal status is not conducive to give a central neuraxial blockade, these become the indications for a general anesthesia. And therefore, over the years, now the ratio has changed. Now, possibly 1 or 2 out of every 10 anesthetics would be a general anesthesia, whereas the remaining 8 or 9 would be a central neuraxial block. Now, parturients, in addition to having an anatomically difficult airway, may also have a physiologically difficult airway because of the physiological changes of pregnancy, and also because of some cardiorespiratory conditions that can complicate pregnancy. For all these reasons, the airway, besides being an anatomically difficult airway, may also become a physiologically difficult airway. And though we may not have time to cover this in detail during today's session, I would request all listeners to go into the guidelines where this is very nicely described. And we took a lot of help from Dr. Sunil Pandya for designing this section of the obstetric guidelines. Now, the physiological changes of pregnancy also place the parturient at an increased risk of aspiration. We always consider that a pregnant patient is a full stomach, and it also shortens the safe apnea time because of two reasons. One, the gravid uterus pushes the diaphragm up, reducing the functional residual capacity, and the combined oxygen consumption of both the mother and the baby shorten the safe apnea time that is available for us to procure a definitive airway. What are the other reasons where obstetric anesthesia is different? Now, when we choose to give a general anesthetic, the technique that is currently still used is the airway of choice is still a tracheal tube, and a modified rapid sequence induction and intubation with application of cricoid force and gentle intermittent positive pressure ventilation using the face mask with the adjustable pressure limiting valve closed down to around 20 centimeters of water, not permitting the pressure within the anesthetic breathing circuit to go beyond 20 centimeters of water, is what is recommended and practiced by most obstetric anesthesiologists in current day practice. Now, the fasting guidelines also have changed. There was a time a few decades ago when the moment the lady goes into labor, they would be asked not to take anything by mouth. But the fasting guidelines have become more liberal nowadays, and we allow clear fluids up to 2 hours prior to a scheduled cesarean delivery, and a light meal, preferably non-fatty meal, up to 6 hours prior to a cesarean delivery. So we need to keep in mind that the fasting guidelines have become less stringent and more allows a pregnant lady to consume clear fluids up to 2 hours and a light meal up to 6 hours. And this prevents the ketosis that can accompany unnecessary long periods of fasting. Airway changes in pregnancy also make the airway more susceptible to trauma. The mucosa is more vascular, the mucosa is more edematous in pregnancy, and this necessitates our limitation of the number of attempts at securing an airway. And this will also be alluded to at several parts of the algorithm. And as already mentioned by Amit, there is already 2 lives that we need to keep in mind. But remember, the mother's life always is given precedence over the unborn baby. So I thought once this preamble is over, we shall now go on to the actual discussion of the algorithm. Now, this is the algorithm in total. And when we look at something as big as this, as complex as this, it is better that we break this down into a number of relevant segments so that we understand the algorithm like a flow chart. And that is what an algorithm is meant to be. We start with a starting point, then we reach a junction. When there is a decision point between a yes and a no, then there are certain criteria that are taken into consideration before we go on to the next step. So let us look at the first step. As I mentioned already, if a general anesthetic is chosen as the technique of choice, currently tracheal intubation is still the most commonly used technique for securing a definitive airway. And this is done using a best optimized attempt at intubation, meaning the proper position is given and the appropriate equipment is kept ready, and the most experienced anesthesiologist attempts intubation. So the best optimized attempt at intubation should be tried. Now, the last 15 years or so have seen many countries using the supraglottic airway as a primary planned airway device. And so we wanted to look at this. What is the best practice statement that we need to suggest for our practitioners in the Indian context? And we came to the conclusion that since the supraglottic airway does not provide protection against aspiration, even if you use the second generation supraglottic airway device, it is better not to use it as a planned primary airway device. However, if the primary technique of tracheal intubation fails, one can fall back upon a supraglottic airway as a rescue device. And this is a class 3 recommendation, class 3 strength of recommendation, where the benefit is equal to the risk. Let's look at the next point that we need to focus on, and that's taking our attention to the superscript A. Now, the superscript A, if you look at the footnote, says that when there is a possibility of a difficult airway, the management plan for the mother as well as the baby, looking into the safety of both the mother and baby, should be discussed with the obstetrician and the neonatologist by the anesthesiologist before the anesthetic induction, should tracheal intubation fail. So we must already have a plan of action should a tracheal intubation fail. And that plan of action we will discuss as we move along the algorithm. The second point that I would like to highlight in the starting black box is that, as we already mentioned, rapid sequence induction and intubation with the adjustable pressure limiting valve closed down to 20 centimeters water is allowed, and gentle positive pressure ventilation with smaller tidal volumes is permitted in all pregnant patients, particularly so in those who are at a risk of developing dangerous hypoxemia. Now, let us say that our primary plan for the airway management succeeds. That is, we have done a rapid sequence induction and intubation with the idea of securing the airway with a cuffed endotracheal tube. If that succeeds, then we must confirm the position of the endotracheal tube with sustained waveform capnography, which means that there should be a 6 to 7 square wave capnographs with no reduction in the end-tidal CO2, and that and only that confirms that the tube is in the trachea. Now, let us say that the primary airway management plan, that is the tracheal intubation, fails. If that is unsuccessful, which means there is an inability to intubate the patient at the first attempt by the senior-most person available, then one must look at what the black arrow is pointing to. It takes our attention to the 3 vertical columns in red, blue, and black that are there to the left side of the algorithm. The first of these, which is red in color, says call for help, which is another term that the All India Difficult Airway Association has coined in the 2025 guidelines, and that is code D. Now, we all know that when you call code blue in a hospital, it means there's a cardiorespiratory arrest. And this code D has been introduced to specifically indicate that this is the code that we need to call when there is an airway-related issue. When there's a difficult airway encountered, one must raise the code D, which is a clear, context-specific, and time-sensitive signal for requesting additional help during airway emergencies. So we would like to introduce this term after much deliberation, and we feel this is going to be a very useful code to be included so that the entire hospital team knows what to respond to when a code D is called for. Now, during our attempts at securing the airway, we should not forget the fact that the patient may be lightening, the plane of anesthesia may be lightening. So the vertical blue box draws our attention to the fact that we must maintain the depth of anesthesia with the top-up of intravenous anesthetic agents. The third black vertical column says deliver nasal oxygen. And this is obviously to sustain the oxygenation within the lung, sustain oxygen entry into the lungs by apneic oxygenation, and we must deliver oxygen at 15 liters per minute through a nasal cannula, or if one has access to a high flow nasal oxygen, one must use equal to or more than 30 liters per minute of oxygen. So do not forget to call for help, code D. Do not forget to maintain the depth of anesthesia, and do not forget to deliver nasal oxygen by either a nasal cannula or a high flow nasal oxygen while senior help is available. Now, that is now draw our attention towards the orange box, which basically gives us the option between 3 devices. The blue box above that highlights the fact that we can, once the primary airway management plan has failed, namely, we have failed in a tracheal intubation at the first attempt, we have called for help. Now, the anesthetic team has the option of using either a second attempt at an endotracheal intubation with a videolaryngoscope if the equipment is available and the expertise is available. They can fall back upon a second generation supraglottic airway, which necessarily provides a good airway for oxygenation and gives a reasonable isolation of the respiratory and the gastric tracts and gives some degree of protection against regurgitation and aspiration, or use the simple face mask with the adjustable pressure limiting valve closed down to 20 centimeters of water. Now, with all this, one must consider re-optimizing the position of the patient. We must ensure that adequate neuromuscular blockade has happened, and we must change tools. As I mentioned, we have the choice now of choosing between a second attempt at tracheal intubation, maybe changing with a videolaryngoscope if the expertise and equipment is available. We must ensure that neuromuscular blockade is complete, and we must change the operator. Definitely, the same person must not use the same technique again and again. Now, drawing your attention to the footnote again, the footnote C says that preferably the most experienced team member in the team must perform the second intubation. If the advanced team has arrived, then the most senior person in the team that has responded to Code D will perform the second intubation attempt. But essentially, the most experienced team member should do the second laryngoscopy. As far as the video laryngoscope is concerned, there is no definite evidence as of now to suggest that the video laryngoscope should be the first technique or the first equipment to be used in the Indian context. In the majority of situations, the direct laryngoscope is available. But I'd like to say that if video laryngoscopes are available in the obstetric suite and the team is comfortable using the video laryngoscope, one can use the video laryngoscope as the first technique or the first equipment of choice when performing a tracheal intubation. It is also definitely the best technique of choice when a difficult airway is anticipated. Now, draw your attention to the limitation of the number of device attempts. I mentioned during the preamble that the obstetric airway is more susceptible to trauma. The mucosa is more friable to damage. The mucosa is more vascular. And because of this, one must limit tracheal intubation to a total of 3 attempts. 2 attempts by the team that is available in the operating room, and the third attempt only by the most experienced anesthesiologist who arrives after the Code D has been activated. Now, one must constantly look at the saturation and ensure that the saturation is more than 95% at all times. And in fact, one member of the team must keep an eye on the time that has passed and must keep calling out the saturation at every 1 or 2 minute interval so that the main team that is actually managing the airway is aware if the SpO2 ever dips below 95%. So the primary objective is to maintain the SpO2 more than 95%, either by placing a supraglottic airway or by a face mask ventilation if tracheal intubation fails. Now, the maximum number of attempts for the supraglottic airway is a maximum of 2 attempts. So 2 plus 1 attempt for tracheal intubation and 2 attempts for the placement of a second generation supraglottic airway. Now, footnote D says that the number of attempts, you must include the first unsuccessful attempt by any member of the team for laryngoscopy intubation is also included as the first attempt. Similarly, the supraglottic airway should be permitted to, or should also be limited to 2 attempts. Now let's look at the face mask, which may be the savior in many situations. So the face mask ventilation is something that we fall back upon always. It's our fallback technique of maintaining the saturation. And for face mask ventilation, not more than 3 failed attempts at face mask ventilation, as mentioned earlier with the APL valve, close down to less than 20 centimeters of water, is something that we should do. Now, as a part of rapid sequence induction and intubation, we use the cricoid force. And remember that in all situations, including the obstetric situation, if any difficulties encountered during face mask ventilation, during tracheal intubation with a poor, which you may have a poor laryngeal view, or the proper siting of a supraglottic airway, in all these three situations, any difficulty in placing any of these three airway devices, one must release the cricoid force completely, because this may be the reason why the difficulty is being encountered. Now, let's look at the situation where, from the orange box, one of these devices has been successful in securing a definitive airway, meaning we are able to maintain the ventilation and maintain the oxygenation. If the endotracheal tube has been placed and has been confirmed with 6 or 7 successful capnograph square wave waveforms, one can continue the anesthetic with the tracheal tube. However, if the other two devices, a supraglottic second generation supraglottic airway device or a face mask, has been the device that has successfully managed to oxygenate the patient, then one needs to look at the maternal and fetal status. If the maternal and fetal status are reassuring, in the interest of both the mother and the baby, one must awaken the mother. So we don't go any further. We have managed to save the day. So in this situation, if there is maternal and fetal status that is reassuring, both mother and baby are fine, one must awaken the patient and regroup, try another technique for this patient. However, if the maternal or fetal status is not reassuring, then what do we do? So in the top part of this box, we have the endotracheal intubation has failed and the supraglottic airway device has been successfully placed. In this case, it's a second generation supraglottic airway device that has been placed. Now, the siting of the supraglottic airway may be good or may not be good. So we look for a leak. If the leak is audible or quantifiable, that means the siting is not good. And if the leak is absent or acceptable, there's a minimal leak, that means the supraglottic airway has been placed properly. In both these situations, if oxygenation is maintained above 95%, the obstetric team must continue and the anesthetic team must continue with the supraglottic airway till baby delivery, and then the situation needs to be reassessed. So to make this a little easier to understand, we can divide this box into two flowcharts in itself. So let us say that there is a leak, it's an audible leak, it's quantifiable, and one proceeds with maybe a slightly improperly placed supraglottic airway where the saturation is maintained above 95% and deliver the baby. At this point, the leak seems significant after the baby delivery, then we need to consider intubation via the supraglottic airway using a fiber optic bronchoscope, provided the equipment and expertise is available. Now let's look at the second flow aspect, which is the lower part of the middle part of this diagram, of this exit box. Here we have the supraglottic airway that has been placed, has been sited well. There is no leak and it's an acceptably placed or acceptably sited supraglottic airway. Once again, the team proceeds with delivery of the baby, and then you can consider continuing with the supraglottic airway for the entire anesthetic. The supraglottic airway needs to be changed with under fiber optic guidance only under two conditions. One, if the airway deteriorates and one starts detecting a leak with the supraglottic airway, or two, the maternal condition worsens. Now, what do we mean by maternal conditions worsens? It means that suppose there is a major maternal blood loss, which is drawing your attention to superscript H in the footnotes. Suppose there is a major maternal blood loss, or there's a major fluid shift in the patient, or there is a full stomach problem. In these situations, one can switch after baby delivery to a more definitive airway, such as a cuffed endotracheal tube, using fiber optic guidance, provided the equipment and expertise is available. Right. Now let's go to the lowermost third of this exit box, namely the two other equipment mentioned in the orange box have failed. We have failed to perform a successful tracheal intubation. We have failed to place a second generation supraglottic airway properly. But we have managed to maintain the saturation above 95% with a face mask ventilation. Now, Since the maternal and fetal status is not reassuring, and now we have the saturation more than 95%, there are 3 clinical flow paths that one can take in this kind of a situation where the face mask ventilation is successful. Now, of these 3, the blue highlighted area says that the patient is apneic or the patient is breathing spontaneously and satisfactorily through the face mask and the saturation is more than 95. In this situation, we can continue the anesthetic till the end while maintaining cricoid force. What happens if the spontaneous breathing has returned and it is unsatisfactory? When the spontaneous breathing has returned and it is unsatisfactory, one must administer an additional dose of neuromuscular blockade, make the patient apneic, maintain cricoid force, and continue the anesthetic till the end of the procedure. Now, remember that when the face mask has been engaged as the definitive airway of choice, is the interface between the anesthetic breathing circuit and the patient's face, one must warn the obstetrician not to exteriorize the uterus and not to apply fundal pressure, because both these situations can lead to an increase in intragastric pressure and can lead to regurgitation and aspiration. Well, let us now look at a situation when all the 3 devices mentioned in the orange box, namely the endotracheal tube, the second generation supraglottic airway, and the face mask ventilation have been unsuccessful. So inability to ventilate using a tracheal tube, a supraglottic airway, or a face mask, despite the best effort by the most experienced person available, after ensuring neuromuscular blockade has been complete, leads us to declare what is called complete ventilation failure, which is a term that we coined in the 2016 guidelines, and we're happy to continue that in the 2025 guidelines. So what do we do when there's a complete ventilation failure? One needs to call for additional help. Remember, we have already called for help. Code D has brought in an extra senior expert along with a difficult airway cart. But this is a situation where we may have to go for a surgical cricothyroidotomy. And therefore, the additional help in this situation essentially is spelling out a surgeon who is capable of performing a surgical tracheostomy. While this is being arranged for, one must continue the efforts at rescue face mask ventilation, trying to maintain the saturation more than 95% at all times. Now, as was mentioned in the adult guidelines, the stab, twist, bougie, endotracheal tube is still the best technique in a non-surgical hands, provided somebody like the anesthesia team is frequently practicing this on mannequins. The other options are a needle cricothyroidotomy with a pressure-regulated jet ventilation, or a wide-bore cannula cricothyroidotomy, provided these are available. But we must have this equipment and have the experience to use it. So the 3 options in the order of choice are: if a surgeon is available, capable of performing a surgical tracheostomy, that is the best technique. The second technique is the surgical tracheostomy surgical cricothyroidotomy performed by an anesthetic colleague who's capable and trained to do it. And the third one is a needle cricothyroidotomy or a wide-bore cricothyroidotomy. Now, in the 2016 guidelines, which was a vertical format which had a hierarchy to the use of various airway equipment, we also had placed the possibility of an arrest happening in the parturient as one of the last boxes. But we felt that the cardiac arrest can happen at any point of management of a parturient. It can happen at the time of induction, maintenance, recovery from anesthesia, and even after the patient has been extubated. So since cardiac arrest can occur at any stage of the anesthetic, we move this box into a red box prominently placed to the right side of the algorithm, and it says initiate CPR and proceed to resuscitative hysterotomy, which is the current term which has replaced post-mortem cesarean section. And this resuscitative hysterotomy has to be performed within 4 minutes of a cardiorespiratory arrest. Now, once suppose we have had the need to perform a surgical access to the airway, we must have a post-procedure plan. The patient is shifted to an intensive care unit, and further airway management plan is continued in the intensive care unit. We wait for the airway edema to settle, edema which has happened because of the pregnancy itself, edema that might have been added on because of our several attempts at airway management with several airway devices. We need to wait for all this to settle down, maybe for 24 to 48 hours, with the patient propped up in a 20 to 30-degree head-up position. We must treat airway edema actively if suspected, monitor for complications of a surgical airway access, and most importantly, counsel the mother and the patient's relatives that the anesthetic team faced an airway emergency, what the nature of the airway emergency was, how it was tackled, and all this is provided in an airway alert card, which must be given to the lady so that she can present it the next time she has an anesthetic, so that the subsequent anesthetic team will be able to manage the patient's airway in a better manner, having been pre-informed with what was the problem on an earlier occasion. Of course, it goes without saying that the hospital records themselves must be well documented and updated, because if the patient comes back to the same hospital, we need to have in addition to the airway alert card, we need to look at the documentation to see who was the anesthetist who managed the patient. If they're still around, we can call them into the operating room to deal with the patient who's known to them. So this brings us to the end of the presentation of the obstetric guidelines. We've already had the adult guidelines and the pediatric guidelines presented. So this completes the third guideline that we have brought out in 2025. And in 2 weeks from now, I think the team will proceed with the guidelines for an at-risk extubation. And with this, I think I will end my presentation. Thank you very much, and I shall open it for questions. I'll leave this on for a little while, and I strongly encourage that for lack of time to keep the presentation concise, we have presented only the major aspects of the obstetric guidelines. I would strongly encourage all the participants to read the article in total so that you will understand the thought process that went on behind the minds of the guideline committee members, which made us come to certain decisions, and of course, strongly supported by evidence and literature, and where it was not available, by a Delphi consensus opinion. Thank you very much. I shall now open it for discussion.
Thank you, sir. Thank you very much for absolutely in-depth and perfect description of the AIDAA 2025 guideline.
Thank you, Amit.
Yeah, so at this, again, I'll welcome our chairperson, Dr. Sunil Pandya, sir.
I just have to
Dr.
say
G.L. Ravindra, sir.
Amit, can I say one more thing?
Yes, sir.
Yeah, I'm so happy that so many obstetric experts have joined us as chairpersons, and unfortunately, Dr. Kajal was not able to join. But thank you, Anju, Sunil, Ravindra, and Dr. Bharati for joining us so that we can collectively deal with any questions that come up from the audience, from the group. Thank you.
Thank you, sir. So now, sir, if you can stop sharing.
Sure. Yeah.
Thank you, sir. So now, right now, we are open for the discussion. I think we can start with the comments from chairperson. Yes, Pandya, sir.
Yeah, thank you, Dr. Professor Ramkumar Venkatesh. As usual, expected, very lucidly presented and very well made guidelines. In fact, nothing has been left in these guidelines, very comprehensively dealt with. So kudos to the entire AIDAA team and AOA team for giving these guidelines to the world, I would say. We are very proud that it come from India, sir. Yes, sir.
We are very, very proud that it's coming from an experienced person like you. Thank you very much. And of course, you also had your inputs at various times. Thank you.
Yeah.
Yeah.
Thank you, sir.
Bharti, madam.
What a wonderful presentation, sir. Excellent. My students have joined in, and this is just the kind of presentation we need for our students to hear. And the problem right now in obstetric area is that we are not doing any cases under general anesthesia. I recently met a senior resident who came from a very prestigious institute, and with me, it was the first time that he had taken up a cesarean section under general anesthesia. So these guidelines are extremely important. I think the simulation of these exercises is also extremely important. And one part which I absolutely loved, and I have been practicing about the AIDAA 2025 guideline, was repeating the neuromuscular block. We had actually been doing it as residents. And I'm so happy somebody put it forward and, it came out in black and white, because it used to be a sin to give a muscle relaxant in a difficult airway. So excellent presentation, sir.
Thank you.
Thank you.
Thank you, ma'am.
In fact, even for difficult laryngeal mask insertion, small dose of muscle relaxant always helps, because many a times the patient just comes out of propofol or effective anesthetic and inadequate depth of anesthesia. You may not, the LMA may not properly seal the larynx. So relaxation is very, very important.
Very well said. An important point, because we never had this problem when we were using thiopentone, but this problem came when we started using propofol.
So one more thing, what we have learned from our experience is, when you're doing bag and mask ventilation in a parturient, we always recommend that you maintain adequate depth of anesthesia and also insert appropriate size oropharyngeal airway, so that you can minimize the inflation pressure, and it's easy to ventilate, because many a times you don't hold the mask properly, and you're giving in your anxiety or this thing, you just increase the submental or submandibular pressure, and you may in fact increase the upper airway. You can compromise the patency of upper airway. So insertion of a appropriate size airway, oropharyngeal airway, and will help in minimizing the inflation pressure, and you can perhaps minimize the risk of aspiration also.
Absolutely. So I think the most important skill is perhaps face mask ventilation.
Yes, sir.
The least glamorous of all, but the most important.
Thank you, Sunil. I completely forgot about adjuncts while talking about face mask ventilation. I think that's very important. You brought it up. Thank you so much.
And not to
keep
use
in mind that even I think the younger members in this group must remember that even introduction of an oropharyngeal airway or a nasopharyngeal airway can produce trauma, since the mucosa is friable, and that can also lead to problems later on. And almost you must choose the right appropriately sized oropharyngeal or nasopharyngeal airway.
Yes.
Okay. Thank you, sir.
Generally, again, we refrain from using NP, nasopharyngeal airway, because again, same thing, mucosal edema and inflated or inflamed or hypertrophic turbinates, which can again very delicate to bleed. They just bleed with simple touch. So even when you're inserting a nasal cannula with 15 liters, again we recommend that it is inserted orally only, so that you can minimize the nasal insertion and whatever little damage you can minimize. Though uncomfortable, but you insert the nasal cannula once the patient is induced with propofol, so that the patient doesn't feel that there is a foreign body inside the throat. Yeah.
So I think quick comment from Ravindra sir and Anju madam, and then we will proceed to a lot of queries are there. So we will, I'll ask chairpersons and speaker Ramkumar sir to attend that. Yeah.
Sir,
Ravindra sir.
As Dr. Ramkumar sir rightly mentioned, maintaining adequate depth of anesthesia becomes very, very important, sir. Otherwise, you may not be able to put an oral airway or even a second attempt at intubation, which is allowed, may become unsuccessful because the anesthetic depth is certainly not there. So maintaining a good depth of anesthesia certainly is a key in managing a difficult airway situation, sir. I totally agree with you, sir.
Yeah.
I would like to reiterate that we have one member, could be even a junior member of the team, who will constantly call out time intervals, the timer, so to say, just like we have for a cardiorespiratory arrest. You have a timer who will ensure that the adequate intravenous agents are given to maintain the depth of anesthesia, and also look at the saturation and keep calling it out, so that the primary airway manager can concentrate on securing the airway.
And maintaining the somebody maintaining the time becomes very, very important, especially in obstetrics, because at 4 minutes, as Dr. Ramkumar sir rightly mentioned, resuscitative hysterotomy, if at all, if God forbid, in the cardiac arrest takes place, and at that time, 4 minutes is the time when the resuscitative hysterotomy has to start, and within 5 minutes it has to be completed. And this is a very important step in resuscitating a cardiorespiratory arrest in a pregnant mother. So it is a resuscitative hysterotomy, which is very, very useful technique. But it's a little difficult to do it many a times. The team, unless proper guidelines are mentioned in that institution, not accepted many times. But still, it is a very useful technique.
Amit, with your permission, can I ask a question? There are so many leading obstetric experts here. Has any one of them had to do a resuscitative hysterotomy at any time? Because I have not had the occasion.
No,
Anju
14 cases, sir.
14 cases. So we have a series from Sunil.
Anju also has.
Anju.
Yeah, Anju ma'am.
Anju has.
Anju ma'am, yeah.
Yeah, thank you so much. I think it was an excellent presentation by Dr. Ramkumar sir, very lucid and excellent. And what I want to highlight here is that the algorithm is such a beautiful algorithm which can be used as a cognitive. And one aspect that we all need to understand, that all along we have alluded to human factors which have a major role to play in obstetric airway management. For example, having good preparation, the best optimized attempt, calling for code D, having a person to, monitor your timelines, your SpO2, and telling you back and forth. I think these are very important things, because not only are the skills and the algorithms important in this particular group of patients, but also what is very, very important is to remember that these are highly complex and cognitive loaded, emotionally situations where human factors have a huge role to play. And as Dr. Bharti said, I think we can have simulations and scenarios where we try to incorporate both. And also in real life, I would recommend that all of you please go and read the entire text of the guideline. It's been very elaborately and very well written. And at the same time, use these algorithms as cognitive aids and assign a person who puts you on track and does not let you to, move away from with the high stress situations that you're faced with. So this is an excellent one. I think we can take questions, Dr. Amit. Yeah.
Thank you, ma'am. So first question came from Dr. Sekar. What is the recommendation of the muscle relaxant? So what he says, we routinely use choline for rapid sequence induction and intubation. If attempts are failed, especially 2+, any recommendation to repeat depolarizing or non-depolarizing at this point of time? Then once we have failed with probably attempts, I mean, he must be highlighting the intubation attempt. And after failed intubation attempt, use of relaxant, I think anyone can take that. I think this was also discussed, but I think Bharti ma'am. So this was I think she only mentioned that use of relaxant is a very important point.
And
yes, ma'am.
Sir had very nicely mentioned in his talk that, and it is very clearly in the guidelines, that it is very important to maintain the relaxation. And yes, we can repeat the muscle relaxant, and should be, to ensure easy airway access.
What is also written in the guideline is that you can choose either of them, but when you're choosing rocuronium, you must ensure that Sugammadex to the dose of 16 milligram per kg body weight is available to you for rapid reversal.
Yes. Yes, sir. Ravindra, sir. You were saying something. Okay.
No.
So Dr. Preeti is asking, is it really possible to awaken the patient? So is again the way sir asked whether you have done resuscitative hysterotomy. Is this situation is possible, or has anyone encountered this? Awaken the patient.
Can I
See,
speak?
yeah, please. Yeah, Anju, please. Yeah.
After Dr. Sunil, yeah.
Yeah. Fortunately, we have had few cases where we couldn't intubate the first and the second attempt, but we could continue with the second generation supraglottic airway device. So the need for awaken the patient didn't arise because the modality is if you can get a successful airway, we have intubating LMA and a second generation LMS which facilitates a proper seal, adequate seal, and with a cuff pressure monitor, an LMA cuff pressure monitor, you can obtain a very good seal. And we continue all the cases we have continued. So in last 30 years of practice, not a single case that we have woken up after a failed intubation. We could manage successfully with laryngeal mask,
Supraglottic
second
airway.
generation LMS, supraglottic airway device.
Yeah. Anju ma'am, I think, have you
Absolutely.
woke up like any scenario where you need?
No,
Yes, sir.
I haven't woken up any scenario. I fully agree with exactly what Dr. Sunil Pandya says. So there have not been instances because since we have the availability of second generation supraglottic devices. And I think the circular algorithm actually tells us that in a context or a situation where we are, say we have a severe preeclamptic patient or a mother who has had augmented labor, is in prolonged second stage and now onto a cesarean section category 1 or 2, I would rather put in a second generation supraglottic airway early on. I just want to emphasize that in one of my instances, awakening the mother was a difficult proposition because it doesn't happen that very well. Despite the fact that there was no urgency, awakening did caused a laryngospasm in one of the instances. So otherwise, we have been able to manage with the second generation. So I think that circular algorithm gives us that kind of freedom to choose depending on the context in which we are.
So similar, I think on that same line, on the basis of this circular algorithm, Dr. Saeed Abdul is asking that probably endotracheal intubation tried twice and failed. Does we have to go to third attempt every time, or we can go in between to a supraglottic airway?
So as I said, the
Ramkumar, sir. Madam, yes,
after Anju, please. Yeah.
Yes, I think it is the same. If the situation warrants, I think we need not move to the third attempt and have a full-blown laryngeal edema to put in a laryngeal mask airway. I hope sir concurs with that.
Yeah.
So I think what I want to say is that the introduction of this orange box, as we were talking about in the algorithm, actually provides the anesthesiologist with 3 options. So we don't need to be single track. We don't have to go along the track of tracheal intubation, and that is a must. And if you already tried twice, you already know what is the airway problem. Remember that after the first attempt, if the same or a more senior person was already available in the operating room, is attempting an intubation, we know what is the problem. What was the grade of laryngoscopy that we obtained? Will a change of position or a change of equipment or maybe use of airway adjuncts help to perform a successful intubation? All this will be pretty clear by the time a second laryngoscopy is done by the team available in the operating room. I would say that the third attempt at tracheal intubation should be done only by a senior person who is more capable of doing it, wait for help to arrive. In the meanwhile, the beauty of that orange box is that it gives you the option that you can choose any of the others. And I think in modern day practice, many of us use supraglottic airway freely, not necessarily in obstetrics, but in most other situations. So we are quite well trained to place a supraglottic airway. And I would therefore, after 2 attempts at intubation, not necessarily go for a third attempt of tracheal intubation, but I'll place a second generation supraglottic airway device. That's the way I would hope that the anesthesia team would go.
In fact, this is where the human behavior and the fixation error comes into play. Like the fixation to put a tube rather than thinking of alternative to tube.
Fixation error. Fixation error, as it's called.
So idea of this circular algorithm and bidirectional arrow is that you can go in any direction depending upon your clinical situation. So it is not necessary that you the first attempt you realize that okay, it is going to be difficult, a help is going to arrive a little late, you need to establish oxygenation, you might put straight away supraglottic airway. You don't need to even attempt twice and then only go for the supraglottic airway, or attempt thrice and then go to supraglottic airway. You can go in either direction after any attempt. So it's not necessary. Those numbers are maximum failed, 3 failed. It's not necessary that you need to do for 3 failed. You do not have to wait for 3 failed. You might decide after 1 failed attempt that yes, this is going to be a difficult situation and I'm not probably able to intubate. You can straight away put supraglottic airway and then ventilate, maintain saturation and decide what next. So it's not necessary to complete the numbers. You can decide even earlier than that. That is maximum 3 failed, but not beyond that. 2 plus 1, that means. Okay. Sir, on the similar line, excellent presentation by Dr. SNY. Can we try with different blade or go for VL? So basically, it is laryngoscopy part where, sir.
Yes, okay. Right. I think I will have to give a little long answer for this because once again, the person who asks this question, it depends on what is the practice in their setup. If video laryngoscope is very freely available and the operator is comfortable using it, you can go for a video laryngoscope even at the first attempt. But what we teach in an academic institution is that generally we still do a direct laryngoscopy first. And the video laryngoscope is not so freely available, even in the obstetric suite. And therefore, the VLS, the video laryngoscope, becomes a rescue option, when there is a difficulty that is faced. What was the other part of the question, Amit?
So basically, sir, it is either, see, the idea is that
any different blade. I think different blade was also
Yeah.
mentioned, correct? So in this, though I did not mention during the presentation, we must all be aware that because of the reduced space between the mouth, between the head and the chest, a short handle laryngoscope is preferred. The Datta laryngoscope is preferred. Conventional Macintosh blade is again preferred. In some institutions, they say that you then use a direct laryngoscopy, maybe with a blade that you can flex the tip, a flexible tip of the blade, which you can use, and then the video laryngoscope. That will be the order of or the sequence in which you will choose the laryngoscope.
So basic idea behind putting this was that you don't repeat same thing again and again.
Yes,
Okay.
correct.
Yes. You need to change, either change blade, device, or change from direct laryngoscopy to video laryngoscopy, use some adjuncts. So don't keep on repeating same thing again and again. That increases chance, like that is not going to improve your success and increase chance your trauma.
So sometimes
question from Kishori.
Amit,
yes, sir. Yes, sir.
To lighten the mood, sometimes in lighter vein, I used to say that the only thing you can't change is the patient. You can change everything else, right? So don't leave that option, unexplored. Because you have this patient, you have to secure some kind of an airway. So use everything that's within your powers. So change position, change tools, change technique, but never repeat the same thing by the same operator for a second time. You're likely to fail. Fail again a second time.
But yeah, Kishori has asked for 2 things. One is fasting guideline, and second is about the POCUS. Anyone can take that. So fasting guideline and the use of ultrasound to, can we quantify and identify, and can we confirm that, okay, this patient is full stomach and this patient is actually having.
So should I go ahead, Amit?
No content.
Go ahead and
yes, sir.
Answer this question.
Yeah.
So it was mentioned during the course of the talk also that the current guidelines that are acceptable is to give clear fluids up to 2 hours prior to a proposed surgery and a light meal, non-fatty meal up to 6 hours before a proposed surgery. So this is an accepted guideline that is being followed. In fact, in some instances, clear fluids are given even up to 1 hour before, but we will not put that in our guideline because what is widely accepted is 2 hours before clear fluids and 6 hours before non-fatty light meal is what is recommended. Now, coming to the role of ultrasound in the obstetric airway, there are, or obstetric management, I would say obstetric management. One is to evaluate the airway itself. Now, I think the ultrasound is now probably going to replace the stethoscope very soon. So all youngsters will be very, very comfortable doing an ultrasound for any purpose. So I think if you have an ultrasound machine available on site, the one thing that you can do is to evaluate the airway and mark the cricothyroid membrane. That is one use for an point of care ultrasound, marking the cricothyroid membrane in the event of our needing to do a surgical cricothyrotomy. That is one thing that we can do, possibly in every patient. Doing it in every parturient help us, will get us better and better at marking the cricothyroid membrane. So I would recommend that if it's freely available, don't waste time on doing that. Freely available, use it for marking the position of the cricothyroid membrane. Now, as far as using the point of care ultrasound for evaluating gastric contents, it has been dealt with in detail in the algorithm. In the write-up, but I will just summarize one or two things. The point of care ultrasound in obstetric patients is performed in one of two positions, either a semi-recumbent position or a right lateral decubitus position, so that you have the gastric antrum clearly seen in the ultrasound picture. Now, one then looks at the cross-sectional area of the gastric antrum. And they have given two or three papers have given different cutoffs, and I will just refer to my notes at this point. I may not remember it offhand. So the cross-sectional area in the supine or semi-recumbent position is the cutoff is around 608 square millimeters. If the cross-sectional area, take it as around 600 square millimeters. If it is more than 600 square millimeters or 6 square centimeters, it equates to a gastric fluid volume of more than 1.5 ml per kg. If you have performed the gastric ultrasound, the ultrasonography has been done, the cross-sectional area of the gastric antrum has been evaluated using the right lateral decubitus position, then a value of anywhere between 9 to 10 square centimeters has been given as the gastric cross-sectional antral area, which points to a fluid volume of equal to or more than 1.5 ml per kg. So uniformly, all papers say that if there is evidence of more than 1.5 ml per kg of fluid available or present in the stomach, it means that there is a risk of aspiration. And that is done by using a point of care ultrasound. So those of you who are adept at doing it, where the machine is freely available, it doesn't take very long to do that, provided there is no maternal or fetal emergency to skip that step. Well, I think we should use it more and more often in present day practice.
Yeah. Any comments on this from chairpersons about use of ultrasound? Like
In
how
fact,
often are we doing it? Yes.
Ultrasound
Yes,
should be a routine part of our airway assessment, especially when you anticipate a difficult airway in parturient. Not only to mark the cricothyroid membrane, but also helps us to assess. We need to use both the linear as well as curvilinear probe to assess the oropharynx and the base of the tongue, the size of the tongue, and the size of the postpharyngeal wall of the base of the tongue. So all these measurements can be done in a awake patient comfortably, and it will give an idea about the ease of intubation. So it should be a routine practice, especially when you have the availability, and you go up on the learning curve as you do more and more ultrasound for the airway. Even there are a few things where cricoid pressures have the efficacy of cricoid pressure. Ultrasound guided has been noted that you don't exactly compress the esophagus when you're giving cricoid pressure, and you're not able to, you do not reduce the absolute risk of aspiration despite cricoid pressure, because the esophagus is little posterolateral to the cricoid, and you may have the upper esophageal sphincter open despite effective cricoid pressure. So ultrasound, I think probably going forward will give a lot of findings and positive things, or perhaps change in guidelines. So probably 3-4 years down the line, AIDAA should come out with updated guidelines on with specific areas.
Thank you, sir.
It's already getting there, Sunil. I think more and more people are recommending its use, but it's not become used wide enough, or the evidence is not that robust yet to make it mandatory.
Yeah. Okay. Next is about physiological difficult airway from Dr. Chandan. So, physiologically difficult airway we have dealt, in a small section. Dr. Sunil sir, can you throw highlight on the physiologically difficult airway and apnea time is not prolonged? So what are the precautions we can take and how we can deal with that?
So when I talk about the physiological difficult airway, we are dealing with situations where regional anesthesia is contraindicated. The patient is in extreme physiology where she is acidotic, she is hyperventilating, she is hypotensive, she is in a state of obstetric shock that requires intubation. So when the patient is in a state of obstetric shock requiring ABCs, effective airway and intubation, the maternal reserves are very, very poor in the sense that they are at the peak of their catecholamine surge. So any little amount of sedation, like even fentanyl or midazolam, is going to induce vasoplegic shock. So you need to be very cautious with what you give. Second thing is because of extreme deranged physiology, like pH of 7 less than 7.1, they're extremely acidotic. And importantly, the patient is tachypneic and hyperventilating and with tachycardia. So the heart-lung interactions are very, very important to understand. So with each inspiration, the preload that is there is probably giving out some cardiac output and she's maintaining some pressures like 70 or 80, whatever the systolic may be.
What's happening?
Hello? Can we mute? Can I request?
Yeah,
Or
I will try to do that, sir.
Yeah.
That's been muted, sir. Please continue.
Yeah. So when the heart-lung reserves are also very compromised, even slightest positive pressure ventilation that you ensue following muscle relaxation can induce the mental cardiac arrest. So we need to be very cautious. So these are the patients where you need to build up the reserve of FRC. So probably in the protocol that we follow is when the patient is breathing spontaneously, connect NIV or HFNC and build up the FRC so that you have some apnea time can be prolonged by a few seconds or probably a couple of more minutes. So giving NIV, effective NIV with CPAP or BiPAP in a patient who is tachypneic will improve in building your oxygen reserve. After that, once you build up this, then or you can achieve HFNC also, as sir said, more than 30 centimeter, 30 liters. Generally, we put 40 to 60 liters with humidifier, and we have collapsible nasal airway so that you can put an effective face mask without removing the nasal airway with HFNC. So that you don't have to disconnect the nasal prongs with HFNC. You can put the face mask over the face and continue. Ketamine, generally we give ketamine is a drug of choice, rocuronium, and cricoid pressure has to be given. And if it impairs the vision, then we remove it. But importantly, you need to preload this patient with crystalloid so that the patient doesn't or the hypertension doesn't worsen. Again, start vasopressors prophylactically, like depending on the type of, level of pressures like noradrenaline or vasopressin if the patient septic shock, depending on the underlying cause. So initiation of vasopressors, giving bolus of crystalloid to maintain the blood pressure, keep a syringe of adrenaline loaded, and slowly give ketamine and then rocuronium, and then gently ventilate. Do not give a strong bag and mask ventilation, because if you are giving a high total volume breath, you are reducing the preload and you are abruptly interrupting the cardiac output. So you need to give low tidal volume positive pressure ventilation. And once the tube is in, it is very important that the subsequent ventilator settings are also very important. You need to maintain the same minute ventilation. You cannot put the respiratory rate as 12 per minute once the patient is intubated. So you need to maintain the same rate and low tidal volume respiration with judicious PEEP. And you should anticipate that post-intubation, this mother is going to collapse or further worsen hemodynamically. And you need to be ready with your pressors and inotropes so that if at all the patient worsens, the things are on. So wide bore cannulas, fluids, pressors, inotropes, understanding heart-lung interaction, the preload and afterload, all these things. And focus also helps in gauging us the quantum of fluid deficit so that it helps us to correct. So whenever you have time, if physiologically compromised airway, do a quick focus, airway as well as the hemodynamics, the volume resuscitation. And then you need to start pressors, fluids, and titrate your relaxants. Titrate your sedation. So generally, we don't give propofol in this case. Ketamine helps us in giving perhaps delayed sequence intubation is what we call, because the patient is restless. Ketamine will obtain that restlessness, and you can buy some time in improving the FRC by continuing FHNC or HFNC or CPAP. So physiological difficult airway again is a separate gamut, and you need to know the physiology, understand the physiology correctly, and then appropriately manage this patient.
Thank you, sir. That was wonderful explanation.
Sunil,
So
I
from
think
this,
I have
yes, sir, Ravindra
Sunil,
sir,
I mean,
and Ramkumar, yes, Ravindra sir.
Sunil, you put it so clearly that it's even clearer than what's written in the guidelines. Thank you so much.
Sir, thank you, sir.
Sir, I have
Ravindra
one
sir.
comment, sir. I come from I work in peripheral setup. Now here, knowing your limitations becomes very, very important, sir. And as far as waking up a mother is concerned, so I was called to, in one of the smaller hospitals, patient, he was a youngster who passed out, and his institution, they are told that refusal to regional anesthesia is an indication for GA. Patient refused spinal anesthesia. He decided to give general anesthesia. He failed to intubate, and I was called in an emergency. And when I reached there are no facilities available. No, but that is the situation. Probably is the right indication to wake up the mother. If there is no problem with the fetal distress or maternal distress, you wake up the patient, refer the patient to Dr. Ramkumar is there, Sunil Pandya is there, you refer the patient there. Yeah. Now you have all choices. Like why when you take a decision to wake up a mother, probably you look at your resources, what you have also into consideration. I think that's a
Thank you, sir. Yeah.
Very good point.
I think, yes. Yes, ma'am.
I said that's a very good point. And I've myself had a similar situation when a senior resident called me up. I was a young faculty at that time, to say that they have given GA for a patient and they're not able to intubate. Now, for me to reach at that place at that time would have taken a lot of time. And I gave the advice, because I knew my resident was not skilled enough with airway, to wake up the patient. And I think the patient survived because at that time the decision was taken. So as you very correctly said, know your limitation, know your resources, and know your skill sets. That's extremely important. Everybody cannot be Dr. Pandya.
Okay, so
in fact,
next is about Sugama Dex. I think we all use Sugama Dex, right? I think everyone agrees that we are using Sugama Dex nowadays.
Yes.
Okay. Yes. So one is the impact of Sugama Dex in pregnancy. Okay, number one, and probably on child. And second is another is probably comment that it is good that we have Sugama Dex, but we should understand that it does not guarantee that hypoxia will be prevented. Of course, that is correct. And we should still follow the steps of algorithm. So that is absolutely correct statement. But any comment about Sugama Dex usage and how are we using it practically?
See, Sugama Dex, conventionally, there was reservation in using in pregnant women because it gets excreted in the breast milk and can get transmitted to the fetus, is what the newborn is what the worry was. But the doses that we use doesn't, that is a, it doesn't, it's just a theoretical risk. So you can use significantly. Having said so, see, every guideline, they say that when you're using rocuronium, keep 16 mg per kg Sugama Dex ready. But the guidelines, none of the guidelines mention that within 4 minutes, if you use 60 milligrams of per kg of Sugama Dex, it's going to reverse rocuronium, because it takes minimum 12 to 14 minutes for reversal. So after a complete dose of rocuronium, where the response of T4 also is suppressed, and for it to, even if you reverse completely with 16 mg per kg, patient may not recover. And this is the laboratory, veterinary data, that they found that the patient still had residual blockade and required airway assistance. So don't be under the impression that if you fail to intubate with rocuronium and within 4 minutes you can give 16 mg and patient will recover. Patient may not recover completely. So you need to be cautious and make sure that the airway maintenance plan A, plan B, and plan C is in the background, and you follow it meticulously.
Yeah. So basically, you still need to follow the guideline. You need to still follow, and then if patient is not recovering, you still need to go and do the emergency cricothyrotomy if at all you are not able to ventilate and maintain the oxygen saturation. One of the question is like who can do the resuscitative hysterectomy?
Can I just add? Sorry to interrupt.
Yes, madam.
Add one thing. I think perhaps the genesis of this question is that there is a controversy regarding the use of Sugama Dex in early pregnancy. In early pregnancy, as it reduces it is theoretically supposed to reduce the progesterone level and has been associated with feature loss in early pregnancy. So I just wanted to highlight that point. So SOAP also does not recommend the use of Sigomadex in a woman with a non-obstetric indication in early to mid-trimester of pregnancy. So just wanted to add that point there.
Thank you. Thank you.
Thank you. So there is a question by Dr. Saeed that who can do the resuscitative hysterotomy and if doctor is not available in the casualty. And I think Anju Madam has answered that. So Anju Madam, if you can again clarify that about the who can do resuscitative hysterotomy and can we do it?
Yeah, so basically, we have to remember that resuscitative hysterotomy is part of maternal CPR. And hence, any of the doctors who are, versed with, and especially I would believe as anesthesiologists, we often are, well versed with the steps of it. It is basically to evacuate the uterus. So that is the whole purpose of doing it. So the maternal hemodynamics can improve and we give the mother a better chance of survival and ROSC. And hence, just because it's a part of CPR, I believe there are no legal issues as far as, doing it is concerned. I would like to have Dr. Sunil Pandya's comments as well on this point here.
So the thing is, suppose if you're working in a setup, remote setup where you don't have obstetricians around, you're the only clinician, then yes, as a part of BLS and ACLS, resuscitative hysterotomy is mandatory and is a part of ACLS. So you should do it rather. But if you have an expert in the hospital, then you should not do it. You should allow the expert to do the procedure. Same like airway management. If you have an anesthesiologist, the first laryngoscope goes in the hands of anesthesiologist rather than an obstetrician or any other physician. So if you don't have anybody else, patient is collapsed and requires or warrants ACLS and hysterotomy, then yes, you can always do it. It's a midline incision. Just deliver the fetus and then leave the uterus and continue CPR till you achieve ROSC.
Thank you, sir. I think there's a comment by Dr. Abhigna that though we are doing it under regional anesthesia, we should use USG as a part of routine pre-anesthesia checkup to assess airway and then note down the parameters, because in case if that doesn't work, spinal, and we may end up in giving general anesthesia.
GA
So
is the backup for all anesthetics.
Yeah, correct.
Yeah.
Can I just add one comment to that?
Yes, ma'am.
There's a lot of talk about POCUS and ultrasound, and I see, it's like the new fashion to keep talking about POCUS and ultrasound. My due apologies to all the POCUS lovers, but I think it's very important that interpretation of the POCUS findings are done correctly, not just doing POCUS. So, as I again said, the skill sets, they are very important. You have an ultrasound, are you interpreting that finding correctly or not? That's very important. So we must bear that in mind whenever we promote POCUS and ultrasound for such important things like airway management.
So probably 10 years down the lane, if the incidence of failed spinal comes down, and if the incidence of failed intubation comes down, then probably we can give credit to ultrasound or POCUS. Otherwise, it's just an additional tour of
yes, provided we are making sure that the interpretation is, like, for example, a simple thing like echocardiography. They say it's operator dependent. So a cardiologist may give you an ejection fraction of 40%, another might give you an ejection fraction of 30%. That's very significant. Just giving an example.
It's an eyeballing,
I've seen this happening with my residents. They use an ultrasound all over the patient's body, and they will absolutely miss out a clinical examination. So let us not forget that clinical examination remains the God. And this is just an assistant for you. And again, in that assistant, you have to interpret your findings very carefully.
Absolutely, bang on.
Thank you. So I think Dr. Rakesh, are you there?
Yes, sir. Yes, sir.
So while he gives the concluding remark about this session, I will prepare for the Kahoot quiz part. Rakesh, sir.
Thank you so much.
Yes, sir, Ramkumar, sir, and then Rakesh, yes.
Amit, while both of you, Rakesh, sorry, just before you, I want to say something. I trained in JIPMA Pondicherry, and the head of the department was Dr. Prabha Kangle, late Dr. Prabha Kangle, who some of you may have heard of. Her interest was in pediatric anesthesia, but she was, of course, other than cardiac. She used to do everything else. And her dictum for the department was that any cesarean section, the case must be attended to by someone no less than a senior resident. And I have seen during my headship at Manipal, seen situations sometimes overheard my junior colleagues say, "Oh, it's only a cesarean. Go give a spinal. I'll be sitting outside." So I think obstetrics should not be taken very lightly. There are two lives, and especially I think it's very important in the days when I was doing my PG, as I mentioned earlier, 8 out of 10 anesthetics was a general anesthetic. So I can imagine what would be the situation if you tell your junior colleague, be it a senior PG or a second year PG, you go start the GA, I'll be around. I think that's a wrong thing to propagate. And somehow I think we need to inculcate this seriousness in our residents, that obstetrics is always two lives, and they never start an obstetric case without a qualified MD around the place. So that, if of course, you can definitely the resident can definitely attempt the intubation, but if that fails, second attempt must be an MD qualified, and third by a senior consultant with obstetric experience who will come in response to Code D. So I just want to mention that Dr. Kangle, I remember her very often when obstetrics anesthesia is discussed, because this used to be her dictum. No less than a senior resident must attend to a cesarean delivery. I think that needs
Very well said. Very well said. And
thank you for these comments. Was the closing remarks, and thank you so much for a wonderful session. I think during the airway management, we have been talking majority of time for the adult anticipated or unanticipated airway. But when we talk of obstetrics, yeah, we're talking about not our patient, but two lives, and very well covered. And if I see the heaviness of the screen right now, I think the heaviness of screen are by the doyens who has, if I combine it, it'd be many decades, actually, the experience they have. And this has come up in last 45 minutes in such a fruitful way. It's like an fruit concentrate coming up from 100 kgs of fruit in a concentrated way, which will be helping. So this concentrate, I'm sure, is helping each one of the listeners today. And I'm sure that they will make the airway management of their patients safe. And the AIDAA guidelines are freely available from the Indian Journal of Anesthesia website. Feel free to download it. Feel free if you need some algorithm in HD images, they can again be downloaded. You can download PPT also. And we'll be putting up today's YouTube on the AIDAA website, so you can see it once again. And very, very special thanks to Dr. Ram Kumar, our teachers of teachers, actually, and for such a wonderful session. And
my teacher.
Dr. Sunil Pandya, Dr. Ravindra JL, Dr. Anju Grewal, Dr. Bharti Vatva, one of my actual teachers who has taught me in Maulana Azad Medical College, but other are also my teachers, which I've learned through various ways. I think this group has given so many pearls. Probably many of them could not have been incorporated into the guidelines because it was coming from their experiences, and experience to matter. People talk about guidelines and evidences, but if we actually see the evidence-based medicine, one of the pillars is actually the experience and the patient preferences. So usually we forget those aspects. So that's a rule where chairperson and experts, when they come together and share their experience, and that matters to us for our safe management, for the safe management of patient, and definitely the budding small kid which is coming out, again, healthy kid which will be coming out if we can do a safe airway management. Thank you once again for sparing time. I know each one of you is a very busy schedule. Thank you once again for coming together and sharing your wisdom and pulse. Now we will be moving towards the quiz aspect, which is again an interesting thing for conference. It is a Kahoot quiz. Each one of you can log in. Today's theme was airway management in obstetric patients. All the questions are related to it. And there will be a not only a certificate, those who have filled the form, I have shared the link earlier. Please fill up the form. You will get a participation certificate for the same. And you will also get a discount voucher for registration with the National Airway Conference, which will be in October at AIIMS New Delhi. So please register for the same. You can see the pin which is coming up. If you just go on the website, type www.kahoot.it. Moment this app opens up, it will ask for a game pin. And today's game pin is 3264272. I repeat, www.kahoot.it. And the game pin for the today is 3264272. You can also scan the QR code that is coming on the screen for joining to the Kahoot quiz today. Wonderful. I think so fast. People are so acquainted in the previous Kahoot quiz that's joining so fast. Welcome Swati, welcome Deepa, Dr. Kumud, Dr. Muthus, Dr. Chandan. I will request, please use your actual names, AS, AB, Puppy. So if you can change your actual names, it will be good for us because we'll be issuing the discount coupon according to the names and the certificate of the winners also on the same name.
And please fill up the Google form so that we have correct information and we can send the certificate as well as discount coupon. So once since we have nearly 60 participants, we'll wait. If there is anyone has any issue, they can put it in the chat box or unmute yourself and speak. Both these things we can, we can identify the problem and find out what can be done for that. Okay, there is Ramkumar sir is fine. So we'll wait for Rakesh, few more, 1 or 2 more minutes and then start 8:30. Yeah.
So once again, I can repeat the Kahoot pin. Somebody is asking, it is 3264272. I'll type on the chat also, so you can copy from there.
Even after the quiz has started, you can still join. You just need to go to Kahoot and put your pin. You can join in between also. I'll wait for 1 more minute and then start. So the pin will be there at the bottom of your screen of this screen. I think Rakesh, we can start. Yeah.
Yes, sir. 27. I think anybody, if some issues, they can type on the chat box. We'll be helping you. We can start, sir.
Okay. So AIDAA obstetric guideline. So again, welcome to quiz 8. Again, I will encourage you to register for National Airway Conference and International Airway Management meeting, which will be there at AIIMS New Delhi from 9 to 11th October. There are more than 30 international faculties have confirmed in-person presence here. There are more than 150 national faculties have confirmed their availability for the conference. This is one day there are workshops and focus learning sessions or the master class on Friday, that is on 9th. And then 10th and 11th, we have a wonderful conference with all aspects of airway management will be covered. So Again, at this stage, I would like to thank my quiz master, Dr. Kiran Mahendru, Dr. Indubala, Dr. Shilpa, and Dr. Shripad, who has helped us in formatting these questions. Thank you. So here, one thing I must tell you, there will be images and photographs, but concentrate on questions and options in the text. Image may not be the exact representations of question and answer. So don't focus on images, focus on questions. You need to give your answers, correct answers in shortest time to score better. So if someone has given a correct answer earlier than that, the points might be more. Some questions have double points, so you can score more on that particular point. So let's go. First, in AIDAA 2020 guideline, what is a primary goal managing unanticipated difficulty in obstetric? Your options: maintain oxygenation, that is saturation more than 95, avoid mask ventilation, rapid intubation, or immediate surgical airway. So we have 36 answers, all of them to the spot. Maintain oxygen more than saturation more than 95. Okay, so let's see who has done it faster.
That's a success
yes,
story.
Sir, Rakesh.
That's a success story for today's excellent webinar. So 36 out of 36, I think perfect. The message is absolutely pinned.
Thank you. And Janvi is leading with 955, very closely by Renita, RP, and Abhishek. Okay, let's go to the next. So how do we prolong the safe apnea time during induction and intubation? So you give 5 liter pre-oxygenated 5 liter per minute face mask, pre-oxygenated with nasal cannula, continuous oxygen via nasal cannula 10 to 15 liter or HFNO or intermittent back mask ventilation. I think we're getting, again, extremely complete message given by the speaker and chairpersons. Continue oxygen via nasal cannula 10 to 15 liter or HFNO. Pre-oxygenation is different. We are talking about giving apneic nasal oxygen or HFNO while apnea.
So the point
okay,
is,
let's see.
So point is here that we just don't have to pre-oxygenate and then remove the mask and ventilate. What is we are saying is that during the airway management technique, the oxygenation should continue at the highest flows. Most of the machines can deliver 15 liters, and now we have HFNO, so use it with 100% FI. So that's the message which should be clear. I think 2 or 3 mentioned about pre-oxygenation. So that was a little earlier concept, but now for last couple of years, we have moved towards the high flow supplementation of oxygen with 100% FI.
Renita has come up to 1600 point and Ruchi is following closely. Yes. Okay. The next question. Okay. Maximum number of tracheal intubation attempt in parturient when saturation is maintained. You have 2 options, 4 options, 2 plus 1, 4 to 5, 3 plus 1, 1 plus 1. Saturation is maintained, okay? Yes, Rakesh, sir.
Sir, I think we can request Ramkumar sir, can you just summarize it? Why do we not want to attempt multiple attempts in obstetric patients, parturients? Why cannot be 3 plus 1 or 4 to 5 attempts with different techniques of different persons?
Right. Yeah. So with each passing attempt, the degree of trauma we are going to create is more. And therefore, we have restricted this to 2 plus 1, the plus 1 being by the most experienced person. Now, it is important that the person or persons available in the operating room before code D is activated can go up to 2 attempts. So it will be with 2 different operators, the most senior operator coming in for the second tracheal intubation attempt. And when the senior person arrives, the 3rd attempt is done. The 3rd attempt is important because the person who arrives on the scene, the senior most expert, also needs to gauge the gravity of the situation so that the future management plans can be planned by that senior anesthesiologist. So the laryngoscopic view that is obtained or any other abnormalities that are picked up by the senior anesthesiologist will also be, help to carry the airway management forward. But mandatorily, we've stuck to 3 because, as I said earlier, each passing attempt causes more and more trauma. That would be my summary for it here.
I fully agree, sir. And especially when we talk about parcherian, because of the hormonal changes and hemodynamic changes, they have more fragile perioral structures, a little edematous, more prone for trauma. And what sir has highlighted an important point, even the 2 attempts should not be the same attempts. There should be some difference, technique, tool, or strategy, or person. So even the initial attempts, it doesn't mean that you put up a scope, you failed, you remove it, and then put the same scope in the same manner. Each attempt should have something different. Use a different blade, use an adjunct, a different operator, or a different positioning of the patient should be there, even for the initial 2 attempts. Absolutely right. We'll move to the next question, sir.
Okay, so Renita is still leading. Behind is Ruchi and then RP and Kumul. Okay. Next. What is recommended pressure limit of IPB during induction of pregnancy? Okay, the correct answer is this in 20. And let's see the sir, any comment about the pressure limits?
Yeah, Ravindra, sir, would you like to comment that why should we restrict ourselves to 20? What happens in pediatric, obstetric patients about the pressures, opening of those pressures and other risks, sir?
So this limit of 20 centimeters of water has been set because of the opening pressure of the lower esophageal sphincter. Right. So if by, even if your a slight amount of air is entering into the esophagus and not entirely into the trachea, there's a possibility that some air can go into the stomach and displace the stomach contents. And therefore, it's kind of linked to the lower esophageal sphincter tone. And we do not want to surpass that and hasten the chances of regurgitation and aspiration.
And going for lesser pressures probably would not generate appropriate.
Will not generate, correct. Though less than 10 should be a better answer, but it will not generate the necessary, pressure difference between the mask and the airway for gases to flow in.
Absolutely.
And
Ravinder, sir,
also in pregnancy, the lower esophageal sphincter tone is low in pregnancy.
Yes.
That's another reason why we should limit it to 20 centimeters.
Yes, thank you. So Renita is still leading with 3763, followed by RP and Janvi. Janvi has come up, but she has gone out of that first 5 number, but she has come back. Okay, let's go to the next. So this is double point question. This needs to be, you need to read the guideline.
So when you see the AIDAA guidelines that come up, it is absolutely based on the evidence synthesis along with the Delphi and expert consensus. And this is with each statement or each step, the evidence has been graded using the AHA level of recommendation. So this is what we are asking here. When we say the supraglottic airway device, each equipment or each strategy may have a good number of RCTs with meta-analysis, but some may not have. So based on this, we want to make our guidelines very robust. And this is one of the robustness of the guidelines. And that's why AIDAA is proud to have such a robust guidelines where we have used evidence and as well as the expertise and experience of the guideline authors and the experts which were involved in guideline making. So for this, the class.
So basically it is, yeah, Rakesh, yes, please explain class 3.
Sir, continue, sir.
So basically class 3 means it is not recommended as a primary device. Our evidence review does not give us enough evidence to suggest that it can be used as a primary device. Some practitioners, some experienced person might be using it, but as a primary device in parturient, the evidence is not sufficient right now to use it as a primary device in parturient.
May I request Dr. Bharti Wadhwa, madam, Bharti ma'am, because I know that you have done, you have experience in using supraglottic airway devices for parturients also in certain situation, but in our guidelines, we have not recommended as a primary device. So can you comment upon what will be the strategy in this, and what could be the reasons that the recommendation has not come up as a level 1 or level 2? What could we do further, and your opinion for the same, madam?
Well, I feel that supraglottic devices are very essential in obstetric airway management. And the reason perhaps why they haven't come up is that, Rakesh, I go for a lot of these inspections as well. I'm working very actively with National Board, and I go to a lot of smaller centers. And Dr. Ravindra might agree with me that when we talk about supraglottic devices, most centers have only eye gels. I am working in MAMC. I have every possible airway device. When we move out of our ivory towers, we realize that perhaps that it is not so commonly used. So that is perhaps one very big, limitation. Every year we come up with a new supraglottic airway device, and often it is a little confusing because they're all the same thing in different packaging. iGel Plus is an excellent device, and perhaps it should now phase out iGel, and we should have that. So that is perhaps one of the reasons why we have not been able to perhaps implement supraglottic devices as actively, and perhaps that is why the evidence is also lacking. And there's a lot of fear still. We've been so ingrained that a definitive airway is the safest airway. Frankly, even I have that at the back of my mind, because that was my primary teaching, that the best airway, whenever in doubt, put an endotracheal tube. So that kind of a mentality is also happens to be there. So
I fully agree, madam.
Sunil Pandya, sir?
Yeah. Can I just add a different perspective?
Yeah, please.
I just go back to 1998 or 797 perhaps, when I had to ventilate a patient with one lung, post-pneumonia. She had pneumonia on one side and she had aspiration on the other side with pneumonia. We connected non-invasive ventilation, and no case reports of using NIV in pregnancy. I'm talking about 97. And then I was a little scared of risk of aspiration, and slowly the patient recovered with NIV. The courage increased, and slowly we had a small series of 8 or 9 cases. And I presented our data in the critical care conference. And one of the examiner was judge was from the UK, and he said, probably if you do this study in UK, you will be chopped. In the sense, it's a very daring study. But if you go now, we have close to 2,000 plus cases where we have given NIV successfully in pregnancy or with different conditions, and when you're able to give BiPAP and CPAP liberally, comfortably, with I would say near zero risk of aspiration, I think it's just a matter of time that laryngeal mask airway may come with subsequent modifications, like iGel Plus has come, and I just today morning I saw one more device. I think it may come in future, which can become a primary device. But currently, yes, we have to go by what the guideline says. But I think going forward, laryngeal mask will become a primary device also, because there are few studies. I don't know how it went through the ethics committee. This study was from Taiwan. I think it was in 2017, where they have done 145 primary elective cesarean sections under laryngeal mask airway with zero risk of aspiration.
Sir, in fact, there are 3,000 patient series, but I think they're not randomized controlled trial where they compare
they're
the
not properly
aspiration
randomized, but you cannot randomize in pregnancy, of course. But again, if you look at the AHA guidelines, 2010 cricket pressures, celiac maneuver was removed from the CPR ACLS guidelines. So going forward, I think we need. I think the leeway will come wherein laryngeal mask will become perhaps 2B or even 2A. Let us see. But as of now, yes, we need to follow what the world says, what the legal law says, and I agree by what AIDAA says.
And the medical legal aspect is a very big deterrent, sir.
Yeah, exactly. That's what actually going by the medical legal, that's important.
It's a very big deterrent.
Thank
It's a very curious situation that the medical legal part is holding you back from making guidelines which will actually make the patient safer.
Absolutely.
Okay, I think we move to the next. What if cricoid fresh force makes airway management difficult? Oh, okay. So the mixed response, but I think release gradually, removed completely is a correct answer. Release gradually was part of our 2016 guideline, but we have changed it to completely. And it doesn't help, I think. Ramkumar sir?
Yeah. Well,
So release gradually. Yes, sir.
Yeah. Yes, Amit has rightly put it. In 2016, we put it that way. But in 2025, we feel that enough evidence has come now that the cricoid pressure must be released when there is any difficulty faced in airway management, be it face mask ventilation, be it supraglottic airway placement or endotracheal intubation. So it must be completely released, and there is no role for partially releasing it. There may be one role if of applying crack. I mean, if you're using a video laryngoscope, maybe the assistant can look at the screen and give an appropriate cricoid pressure without distorting the larynx. That may be the only situation. But barring that, I think it should be completely released. If there's any difficulty, must be completely released. There's no
Thank you, sir.
role for partial release.
Okay, let's see the result. So Vaishali has come up. Now the leaderboard is changing. Vaishali, Aditya, Samuel. So now the leaderboard is completely different. Okay. Double point question. That's about fasting. And let's see. I think majority of the given correct answer. 2 hours is, as Ramkumar sir already explained in the discussion also, is our guideline for the clear fuel. Okay, let's see the leaderboard. Okay, so Vaishali, Aditya, and Samuel are still leading. Rocuronic. Okay, that also was a part of our discussion. I think majority of them is absolutely given correctly. I think our message is very clear and precise. And still Vaishali is leading and followed by Aditya and Samuel. Okay, where is Renita now? You are, okay, 14. Double point question. What is true regarding gastric USG? This was also discussed. Let's see. So more than 1.5 suggests full stomach. Okay. Let's see the leaderboard. So Samuel has come up just behind the Vaishali and Aditya. Aditya is just behind the Samuel. So surgery is not urgent and intubation has failed. Oxygenation is stable. What would be your best option? again. So surgery is not urgent. That means in that situation, even you have put supraglottic airway, but if it is not urgent, the best option is wake up the patient. The supraglottic airway, if you're used, and then if patient fetal and maternal conditions are not reassuring, then only you proceed with supraglottic airway. But otherwise, intubation is failed, surgery is not urgent, oxygenation is stable, you should wake up the patient. Vaishal is leading, and the last question. This you need to do it correct and right. Everyone would know the correct one, but you need to do it fast. Fantastic. All answers within 10 to 15 seconds, less than 10 seconds. Nearly everyone is there. Let's see. So, maximum 2 attempts. 3 is not there. It is for 2 plus 1 is for intubation. Supraglottic airway, only 2 attempts. And we see the number 3 is GN. Please give us your name. Samuel is number 2, and number 3 with 13,000 point is Vaishali. Okay, thank you. Over to Rakesh.
Thank you so much. After this interesting quiz, I'm sure many of the important points could be highlighted once again through this quiz. So keep in touch. This Quizinar, which is an interesting initiative of the AIDAA and NAC 2026, quiz plus webinar to combine both. A little learning, a little enjoyment, and a little gift voucher also to the winners with certificates. So keep tuned in, and we'll see you with another good webinar on extubation guidelines in next Tuesday, again with one of the lead authors. You will get more insight into understanding, as we have discussed for tracheal intubation, what are the concerns during the extubation. Both are equally important. What are those nitty-gritties? What are the updates? What are the updates in 2025 AIDAA extubation guidelines? And this time, as we have released certain new things, the circular algorithm, the concept of code D. Similar, there is something new which will be there in the extubation guidelines also. And for the first time, AIDAA have tried to touch the extubation guidelines with respect to the pediatric population as well, which is again interesting, and certain safe mnemonic, which is an important parameter to make the extubation also safe. So keep in touch, and all are most welcome at International Airway Congress, National Airway Conference, along with International Airway Management Meeting, with more than 35 confirmed international faculty, more than 150 faculty from all over India. It will be grand bonanza. Learn the techniques from the experts and doyens in this field from national and international. And you are most welcome in October to AIIMS New Delhi for National Airway Conference and International Airway Management Meeting. Thank you so much, and see you soon with another interesting Quizinar.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, everyone, and good night.